We are live now on YouTube. Just wait for the 1 minute.
Good evening, everyone.
We'll just wait for a minute. Once we go live on Facebook, then we will start.
Sure.
Yeah, 1 more minute. We are live now on YouTube.
Shall we, Sudhir?
1 second. We are just going live on Facebook.
I think we are live on Facebook.
You checked it?
Yes, we are live on Facebook and YouTube.
Okay, so you can start.
A very good evening to everyone. I'll just... Yes, we are live on Facebook and YouTube.
Yeah, okay. Start.
A very good evening to everyone. So I'm delighted to welcome everyone to the Cataract Update 17, Treat, Train and Serve. I'm Dr. Shikha Bassi, Senior Consultant, Shankar Netralia, your host for the program, and will be moderating the sessions with Dr. R.R. Sudhir, my colleague at Shankar Netralia, a Senior Consultant in the Cornea Department. The update is, as usual, divided into 3 sessions, which will have 3 talks followed by a panel discussion by a very esteemed panel. We are very happy to have with us Dr. Adi Ravindran, who is the chairman of Arvind Eye Care Systems. It's an honor to have you with us, sir. Welcome to the update. It's a matter of great pride for us to have with us the President of Medical Research Foundation, Shankar Netralia, Dr. Girish Shiva Rao, with us to grace the panel. Welcome to the update, sir. We also have Dr. B. Shanta, Director of the Department of Glaucoma at Shankar Netralia. It's indeed a matter of honor to have you with us, ma'am. Next, we have Dr. Sri Priya Krishnamurthy, who has trained very many postgraduates as cataract surgeons at Shankar Netralia. Presently, she is the Director of Department of General Ophthalmology, and she's also a part of Glaucoma Department as a Senior Consultant. Welcome, Priya. Lastly, we have Dr. Rajesh PS, who's in charge of CU Shah Shankar Netralia. He's a Senior Consultant with the Community Ophthalmology at Shankar Netralia, and he's in charge of the Mobile Eye Surgical Unit, which is doing great work in the rural and the tribal parts of Tamil Nadu. Welcome, Rajesh. So with that, once again, I welcome all the panelists, all the speakers, and the audience. And let's begin today's update. And to do that, I invite Dr. L. Vijaya, Distinguished Senior Consultant, Glaucoma Services, to give her first talk on cataract surgery in nanophthalmic eyes. Over to you, ma'am.
Thank you, Shika, for the invitation and also for hosting this meeting. And the next 10 minutes or so, I will be talking to you on management of a difficult situation, That's an anophthalmos from the cataract perspective. And what kind of a precautions we take when we deal with these kind of patients. And by the non-ophthalmos basically is a congenital micro-ophthalmos. We can call
Your
it as a,
presentation is not live, ma'am.
pardon?
Your slideshow is not happening.
No, it's I'm sharing.
No,
You're
you're sharing, but it's not on the slideshow.
It is on slideshow. The one you see on the right side is only part of the. This is not slideshow.
No, you have to open the slide, ma'am. It's not opened as.
This is the slideshow.
We're not able to see it, Vijaya.
No, but it says I'm sharing here.
So your
Would
sharing
you
is
like
fine.
to?
Sharing is fine, but the slides are not there, ma'am.
How come?
Probably
We are actually seeing the folder.
I will stop and again share.
Yes.
Now?
No, ma'am.
I can see it here. Your screen sharing.
Yeah, your screen sharing is happening, but we are not able to see your PowerPoint.
It's a blank screen for us.
Same thing, I have tried it on the record meeting information, hide names, hide video panel. Can I come back? Maybe you can take somebody else.
Sure, ma'am. Sure, ma'am. You can stop share screen.
Yeah, I will do that. Stop share.
Yes. So I think we'll begin with the second session first. We'll invite Dr. Foss, and for that I'll just give a brief introduction.
What are you doing? I'm in a webinar. I messaged you.
Sudhir?
Yeah. Welcome, Dr. Foss, for this presentation. Dr. Foss is he's a honorary professor at Nottingham University Hospital, and he has a lot of experience in the training programs for ophthalmology, and he has worked a lot on simulation, and he's a member of several NICE committees, including the AMD Guidelines Committee, and he has a number of research interests over the years, including cataract surgery, Avastin in the treatment of macular degeneration, and virtual reality technology in the treatment of amblyopia, and mathematical modeling and medical education. It's a pleasure to have you, and we like you to share your presentation on tools and techniques for the trainings in cataract surgery. Dr. Foss, you can take over. Dr. Foss, can you, yeah, you can start your presentation.
That's
Yes.
right. Sorry, can you see my screen?
Yeah, yeah.
Thank you. I would like to spend the next 14 minutes discussing the problem of the learning curve for junior surgeons. It's quite clear that patients of today would like safe surgery, while the patients tomorrow want a supply of well-trained surgeons. The little graphic at the bottom is Pandora's box, and the thing we keep secret and locked away is the problem of the learning curve. Clearly, if patients fully understood the implications of the learning curve, they are unlikely to consent for a junior surgeon to do their operation. Traditional training is based on the apprenticeship model, or what I would call the have-a-go model. Normally, a junior surgeon is attached to a senior surgeon, and assuming they get on well, the senior surgeon will allow the junior surgeon to do some cases under supervision. Nonetheless, the complication rate for the first 8 to 10% of cases, sorry, for the first 40 cases is about 8 to 10%. And the next 40 cases is around 4 to 5%, compared to around 1 to 2% for a consultant. If you compare the risk factors for complication, we all know that big eyes or small pupils, pseudoexfoliation and mature cataracts all carry a 2 to 3-fold risk of a complication, but these risks are small compared to the risks of a junior surgeon in their first 40 cases, which is about a factor of times 10. This makes a junior surgeon the dominant risk. So this is the learning curve. So this is data from a trainee showing, and it's what is plotted here is the posterior capsule rupture rate as a rolling average over 50 cases. So for example, in this case, the trainee for the first 50 cases had a rupture rate of 16%, dropping down after 100 cases to roughly level of consultant of 1 to 2%. Medicine is not the only place where you come across a learning curve. Clearly, the military have similar issues. So for example, this is the RAF data for the Battle of Britain, the famous The Few. And it was noted that a novice pilot had only a small chance of surviving their first combat. After 5 successful combats, the chance of surviving a 6th combat was about 95%. What you might call a consultant pilot, what they termed aces, who had achieved 5 kills, was achieved by less than 10% of all pilots. And the question facing the military was this selection or was this experience? America has got 2 air forces, an Army Air Force and a Navy Air Force. And during the Vietnam War in the early years, the kill rate was roughly 2 to 1. The Americans weren't very pleased with that. And then in the year 1969, there were 2 developments. The first, that was the year that President Nixon declared no-fly zone over North Vietnam, so aerial hostilities ceased for 1 year. And that same year, the Navy Air Force, but not the Army Air Force, put together their Top Gun training school. And this was a simulator-based training program. In 1970, when hostilities resumed, the Navy Air Force raw pilots' kill rate was 12 to 1 compared to the 2 to 1 ratio for the Army pilots. This showed quite clearly it was not selection, it was experience, and it could be trained. Now, in medicine, I think you have a particular problem, and this is the person I call the villain. This is Bertrand Russell. He was a pacifist, he was a mathematician and a philosopher, and he was extremely influential. And one of these things he believed that the law of causality, he considered to be a relic of a bygone age. Unfortunately for medicine, Pearson, father of medical statistics, the second picture on the diagram, this gentleman here, believed in this. And most of medical statistics are all based on tests of association, not tests of causality. And in fact, the only time that causality ever appears into medical thinking is the randomized controlled trial, which is the only evidence that Cochrane association was considered admissible. In fact, R.A. Fisher refused to believe that smoking caused lung cancer because there was never a randomized controlled trial of smoking showing that it did. Interestingly, he was also a lifelong smoker himself. This is not the case in industry. So for example, the Six Sigma program introduced by Motorola and adopted by General Electric had an improvement program based on strong leadership, a clear focus on measurable outcomes, continuous assessment. It was very responsive to changes. You're allowed to change more than one thing at a time, in contrast to classic RCT, where you only allowed to change one thing and see what happens. And it was based very clearly on causal thinking. Clearly, this is not evidence-based medicine that's understood by the Cochrane collaboration, and its main justification that it works. So in surgical training, there are clear training targets. We have surgical numbers we want people to complete. We can monitor the complication rates. At the same time, trainees need to pass exams, and they need to acquire competencies. So on the basis of this, the training program at Nottingham was redesigned. Simulators were central to surgical training. And we also thought that training should be structured. And we use the terms of deliberate practice and intensive practice. We also made a clear distinction between skills acquisition, which is performance, versus retention, which is learning. And of course, the obvious point that experience without knowledge of results is no experience at all. And finally, to undertake error analysis for complications or mistakes. So this was back in 2009, one of the earliest centers to acquire a cataract simulator, which I believe you have yourselves. And when it came to the actual training, we adopted the principles from the Top Gun school. So you started off learning part task training, such as inserting lenses or doing soft lens mantle aspiration, and building up through stages to the creme de mission training, which in our case is be able to do complete cataract lists. It's not, with learning, it's not just the hours of practice, but it's also the type of practice, and in particular something called deliberate practice. And this is the hallmark of true experts. Like, for example, I'm a keen chess player, so Vishy Anand would be an example. The feature of deliberate practice is that it requires a maximum concentration. You focus in great detail on every aspect of the task. And the key point about it is that it's exhausting. The maximum that it can be sustained is only about 4 hours a day. And as an aside, if a trainee is concentrating hard on the operation, they can't be listening to people speaking at the same time. So, and it takes quite a lot of discipline, but the trainer needs to be quiet while the trainee is operating. In the United Kingdom, our curriculum is very much front-loaded. So in the first year, for example, that nearly 60 competencies are meant to be acquired, compared to really around 10 to 20 for the rest of the year of the course. They've also got 2 exams they must pass by the end of year 3, the FRC Op Pass 1 and the optics module. The implications of deliberate practice is clear cut. If the maximum you can do is 4 hours in a day, the maximum you can do in a week is 20 hours. And the other point about it is quite domain specific. We do not believe in this idea of transferable skills. So again, to use chess and analogy, an expert in the Slav defense, the diagram on my left, does not mean they're an expert in the King's Indian defense, the diagram on the right. When starting off, we must distinguish between performance and learning. So block practice is good for rapid improvements in performance, but mixed task is much better for learning and retention. So for example, as a tennis player, block practice would be like repeating your backhand time and time again to make it nice smoothly, but there's no substitute then for playing whole games of tennis where you can do a backhand and forehand at will. The next point to make, not just deliberate practice, but intensive practice, spacing is important for learning and retention. When you do a task, you have an immediate learning effect, and as soon as you complete a task, you start to forget. So the spacing is too far apart, then you've lost most of the learning benefit before you repeat the task. If you want to learn quickly, it's good for the tasks to be repeated at relatively short intervals. So in order to put this all together, it seemed logical to us that we, in contrast to traditional training programs, that the trainees did no cataract surgery during their first 2 years, but concentrated on passing their exams and getting the key competencies out of the way. It also meant they had time to complete courses on the simulator, and the training list they missed out on in the first 2 years were given back to them in year 3. So it meant that in the first 6 months of year 3, they got a cataract list every day. And so by the end of year 3, they had caught up completely in terms of number of lists done and number of cases completed. So for the simulator, they were expected to spend at least 50 hours in the simulator before they did their first case on a human. And the simulator had a number of exercises in it, which I meant to complete it. I meant to complete it with a high pass mark. The lists in theatre, like most training lists, were meant to be dedicated training lists with reduced case numbers, and they did reverse module training. That meant end of the operation, washing out the viscoelastic, moving backwards, putting the lens in, soft lens matter. And by the end of 8 weeks, they were able to do whole cases. All cases were videoed, and if there was a complication, the video was saved and then reviewed later. Like any training program, we were very lucky. We had good vitreoretinal backup in case of any mishaps. And these were results of the first trainees that went through this program. The blue curve you've seen before, that is the learning curve of a trainee from the traditional program, showing the classic learning curve. And you'll notice that the first trainees that went through the new program, there quite simply is no learning curve. They were starting off at the level of ACEs. So these are the results in terms of figures. The complication rates, for example, in the first 60 cases was 1.1%, and the best we could find in literature was over 5%. So this is an 80% reduction in complications. When the program was externally reviewed in 2012 by the college, we got good reviews. The program they got good experience, the numbers they got were good. The feedback for the trainees themselves was very positive. They liked the new program. And they also did very well on other measurable outcomes, such as exam pass rates. So the conclusion of this work was that simulation has an important role to play, that it should be part of a structured program. And particularly, I note in some programs, I've noticed that some people, they have simulator simultaneously operating on patients, which seems to be illogical. It's like expecting a fighter pilot to go to combat first and do a simulator second. It makes much more sense that you do your simulator work first, and once that's completed, then start on patients. I'd like to be very clear that what I presented is not evidence in the traditional randomized controlled trial sort of evidence that medicine likes, but I would argue that the feasibility is good and that the justification is it works. So in conclusion, we can open Pandora's box, we can be truthful of our patients, and we can train the surgeons for tomorrow safely without compromising the safety of patients today. Thank you.
Thank you, Dr. Foss. That was indeed excellent presentation to show us that simulation can reduce the complication rate and make the learning curve much faster. You can stop sharing the presentation.
Okay. I'll just think one comment there is more than just simulation. I think that also the focusing on intensive and deliberate practice was also a very important part of it.
Okay. I just opened this discussion to the panelists. Ma'am, we can just wait. We'll finish off the discussion and then take it up.
Yeah, no. Is it?
Yeah, it's there, ma'am, now. So be ready after this discussion. We'll have your talk. It's there right
Okay.
now.
Yeah, that's fine.
Yeah.
Okay.
Great.
Dr. Foss, there was one small question which people been asking. They're asking us if the person is not getting trained, the student is not getting trained even after the simulation. So what will you, how will you make him fast forward?
I'm sorry, I don't quite.
Yeah.
So you're saying, I don't quite follow that.
See, during the training part in the simulation, if somebody
Yes.
is not moving forward, how
Yes.
do you handle these situations?
They're not progressing on simulation.
Yeah, they're
Well,
not learning. Yeah.
Okay.
They're not
Well,
able to
the great
achieve
joy.
the task. Yes.
Okay. The great joy of simulation, it's completely safe, so they can take as much time as they need. So some people might progress more quickly, more slowly. If they're really not progressing in simulation, then you've got to start thinking about other things. The only trainee we had, who I am afraid I only got at the end of the training program from another centre, and she did not progress. And her problem, it transpired, was she was naturally left-handed, but been forced all her career to operate with her right hand. And it was too late to take it back and start all over. So that was very sad. We were also banned for testing for depth perception. Clearly, 1 to 2% of the population lack depth perception, and they clearly would potentially struggle as well. So those are the sort of things you have to think of. But I think the principle is that assuming you've got 10 fingers and 10 toes, i.e. you're kind of physically normal, then you should be trainable.
Yeah. I think one thing which we found during our training programs, many of them when they start training, I think many of them have a difficulty in depth perception. I think they need a lot of orthoptic evaluation, getting better with their orthoptic exercises, and then putting them into the training program. I think we have two great people who have done a lot of training. I will open and take comments from Dr. Ravindran and Dr. Sripriya. Dr. Ravindran sir, probably you can give us your way in which how Arvind Eye Hospital handles the training programs and your experience with simulation, wet lab, and a combination.
Yeah.
And then Dr. Sripriya.
Thanks, Dr. Sudhir and also Dr. Foss for the nice presentation. I mean, in Aravind, we have been only relying on, not so much on the simulators, but on animal eyes mostly. So we do a lot of our, initially we ask them to learn suturing on a sponge just to get the eye-hand coordination. Maybe they do it for maybe like each day they have to put about 30, 40 sutures just to get that handling of microsurgical instruments and also get the eye-hand coordination. For that, just a simple industrial microscopes are enough. So the investment part is also less. So once they get through that, then we give them the animal eyes and the goat's eye especially, and then they practice on that. And the only place where we use a simulator is to get trained in the capsular access part. So we have just one simulator and then it is used. But as you said, no, they spend at least about 2 hours every day for about a month. Roughly about 50, 60 hours is what they spend. And we have a dedicated trainer who will oversee the training part of it. Once they finish that, then they move towards the surgery. And again, we believe in starting them much early. So they start the wet lab training the 6th or 7th month after joining the course. The 8th month of their first year, they do some surgical cases. Typically, what we do is we ask them to do 3 or 4 cases, just cutting only the assistant surgeon. They probably cut only the conjunctiva. They do the peritomy part. The next day, they may do that part plus making the incision for 3 or 4 cases. Then similarly, every day they do 2 or 3, but one step at a time they learn. And when they do a full case, probably they just do 1 case. So we try to give them like 15 independent cases during the first month of training. So which we feel making them do that, we can minimize our overseeing the later part of their training program. So, but what the complication rates you are showing is much, much lower than us. Our complication rate after 100 cases is around 2.5% or 2.6. I think you are showing lower than that.
Well, 2.5% is certainly a lot better than most centres. We were going to start using animal eyes. Getting animal eyes in the UK is not so straightforward. And the simulator became available at that time. So we were very lucky to have a simulator. Simulator is expensive. That's the major downside of the simulator.
Yeah.
Its great advantage, though, is it requires no preparation. So if a trainee wanted to come in the evening to play on it at the weekend, they can. It requires no organisation from us. They only have to organise them themselves. But I think the other thing that makes a big difference is the intensive training. So they learn, if they're doing a list every single day, then they learn very quickly.
Okay.
And I think it's a case of the more you do, the less PCs you rupture.
Sure, yeah. I think we have seen if they cross 300 cases, then the complication rates is around 1.2, 1.3%.
Yes. The data we see here, that under traditional training programs, it takes at least 100 cases before you come anywhere close to what you might call
the other two things that significantly increase the complication rate is the nature of cataract and also the preoperative vision. So the cases where the cataract is advanced and the vision is less than 6/60, so the complication rates are also higher. So wherever the preoperative vision is better, the complication rates we have seen it to be lower. So
we risk stratify, so they would not be expected to be complicated cases to start with.
Yeah. But the type of patients we get is a very different.
Oh, I'm sure. No, My first ever cataract I did in India, but that was 40 years ago. And, yeah, it's a different practice, but not directly comparable.
And they all do only manual small incision, and only towards the end of their training program they do phaco. So all that differences are also there.
Yeah, no, we only do phaco. So I think with most extracapsular surgeons, complication rates are between 2 and 5%, whereas phaco surgeons is about 1%. So, and it's the nature of the technique.
Yeah, Shripriya, I think she is one of the trainer who have done a lot of training for phaco fellows, and we had a very good phaco fellowship program starting almost in 1998, I think, and it's continuing, and everybody is envy of this phaco program, which is an advanced cataract surgery program. Shripriya, can you highlight on experience?
Thank you, Dr. Sudhir. Dr. Fawaz, your talk was very interesting, and actually Dr. Arun was the first phaco trainer coordinator when he started out, when the program started. Our training is very similar to what Dr. Ravindran said. We asked them to start practicing suturing on gauze or sponge, and then we put them on the animal models before they migrate to the human eye. But we also have the consultants scrubbed in and viewing them through the side port. So as they do, we literally physically hold their hands and guide them through the surgical process. And we are able to intervene before the complication occurs. And so their complication rate is much lower than what a trainee should have. We have only about a 2 to 2.5% complication rate even when they are trainees. It is because probably we take over the surgery during the prior to the complication actually occurring. And I absolutely agree with Dr. Fawaz that they need to do it at a regular interval, because they do have postings in which they come every day to the theater, and also they come once a week. So any new technique that we are starting, whether it be extracapsular or phacoemulsification, we ask them to start it in their tenure when they come every day. Whereas the trained people are the ones who do it once a week, because we find that it's a complete undo button. They're completely forgotten what they learned the previous week. And if the supervisor is different, they have the added problem that one person wants them to hold an instrument in one way and the other person gives them another tip. So it has its own plus and minuses. So,
all that resonates.
Yes, and I was wondering about the simulator usage. The one thing that we found was in the simulator, they are fantastic, but when they come to the human eye, we realize that they have stereopsis issues, which does not get reflected. The subtle stereopsis issues don't get reflected when they are on the simulator or on the goat's eye animal model. But when they come to the human eye, we find them a little too rough with the tissue handling, and we start wondering why it occurs. And whereas we find a totally different scoring when they have the virtual simulator. Do you have any such scenario? We have almost every 10 or 15 candidates, we have one person with stereopsis issues, especially people who are wearing glasses. It's always overcorrected or undercorrected.
We used to, when I started, routinely test all applicants to our training program for stereopsis as part of the selection process. And we were forced to stop doing that because of the Disability Act, which is a complete misreading of the Act, and is what I would call a blood boiler. So now we have to wait until they've got problems and then test them, which is just ludicrous, because patient safety comes first. Luckily, to date, we've not had that problem for a long time. The word was out there. We did it, yes.
Dr. Ravindran,
but it's something you can screen for. It is, and I think a very strong case can be made as a part of your selection process for training should be screening for stereopsis.
True.
Yeah.
Dr. Ravindran, you come across such people?
Yes, definitely. First thing we check is that, if they are not doing well and they have more problems, not able to have the complications, not able to do the steps properly, is something we check immediately. So as you said, we don't do it in the beginning, but we do it as they get into the regular surgical practice. Yeah.
The other issue I have come across, though, is left hand being forced to operate the right hand from childhood. And that's another reason why they can be a bit clumsy.
So there was a question asking, how do you achieve bidexterity for a fresher in practice? Because they need to handle with both the hands.
Well, the simulator covers that. I mean,
Yeah, the
simulator
simulator
allows.
is for it, basically, yes.
Yeah, so it's just practice, basically. I mean, view I've come up with, assuming they're physically normal. By physically normal, I mean they've got binocular vision and they haven't got any obvious logical deficit, then in principle they're trainable.
Yeah. Dr. Ashish, you want to add up your experience from Chitrakoot, your training programs?
Yeah, first of all, I'd like to congratulate Dr. Foss. It was an excellent presentation. We also follow the model the first 3 months. Am I audible, Dr. Sudhir?
Yes, yes.
Yeah, okay. So first, the first 3 months we give a wet lab training. And it's mostly on the animal eyes before they start off going to the regular theater. And just as Dr. Ravindan sir was saying, we also give a surgery in a graded manner, that we first ask them to do a steps a few days or a few months. The first few months they do the steps, and gradually we increase the number of steps. And as far as phaco is concerned, as you were talking about the using of both hands, so what we advise them is to start eating food with the left hand. So a lot of them, they improve if they start eating food with the left hand. So that's what we tell them. And we've also got a phaco development program. So there we have a person from the industry as well who stays along and tells them, he takes a photograph of their hand position. There are a lot of problems with the weight on the wound and weight transfer on the side ports. And then that helps a lot. I've seen that. So I've seen people improving within 11 days of starting phaco. If they are doing a good SICS, they definitely improve within those days.
What you're describing there is what I would call deliberate practice, where you're talking maximum concentration and focusing on the very small details. Yes, I would totally agree with that. And again, those sort of issues can be ironed out in the simulator.
So this can I add one small tip. I think it was, I started my cataract surgery with the Van Griffin knife. And those days, for the left eyes, we used to have that left hand we have to use with the knife. So my professor asked me to brush my teeth with my left hand. He said that will improve your dexterity. Okay.
Dr. Sudhir, I just want to add one point. For the dexterity, we used to write with our non-dominant hand every day. So for quite some time, maybe 2-3 months. So which really helped us to use our left hand.
Thanks. There was one more question, which was like, I think when we start assessing the trainees, we need to have a certain guidelines. I think ICO has rubrics, which is one of the well-designed rubrics scoring system to assess how the trainee progress over a period of time. And we tried also, Sripriya could probably help tell us, because when we go for a training, we used to vigorously score them at the end of the procedure for each step on a scale of 5. And even the trainees also do them by themselves. How did they do? So we can usually compare them, how the trainer has scored and how the trainee felt their score levels are. I think they are very good rubrics program, rubrics sheet, which is available in ICO for both SICS, extracapsular cataract extraction, and for phaco, but they are very detailed. I think Sripriya did a little modification, a shortcut of it.
Yeah,
So that,
part of the Ratan Tata program. At that time, actually, Oscar score did not exist. So it came in much later. So we used to have a competence and confidence scoring, as we used to call it. Confidence score is what the candidate grades themselves for each step, capsulorhexis, hydrodissection, and they used to score themselves from 0 to 5. And the competence used to be by the supervisor who has supervised their surgery. And overall, we found that the confidence and the competence score started matching towards the end of their program. And initially, the confidence score used to be very low, and the supervisor used to grade them much higher. And then the second phase, mid-phase, it used to be the confidence had shot up, and they used to score themselves very high, whereas we used to score them low. And then we sort of plateau off at the end of the program. The other thing, there was also a paper about it. The confidence score of male much higher than the confidence score of the females. And we also used to find the same thing between city kids and smaller towns. The smaller town people always used to grade themselves lower than the city bred material of their competence.
Sounds a bit like Kruger-Dunning effect.
So
My
this is
only
What about
observation.
the
Sorry?
wet lab? Sorry, what about the wet lab Oscar score like that? They have a wet lab training score also. So do you have anything like that in practice? Any of the panelists can tell, because wet lab is quite monotonous. So unless you have somebody right there to monitor them, people tend to just sit in the wet lab and do things slowly or play around with the tissues rather than actually put in those 40, 50 cases that you were talking about, Dr. Foss. It's very
Well,
difficult for us
simulator.
to maintain their tempo there.
Okay, the simulator will give them a score, and they'll put the scores out over time. So that's it. Just one observation on feedback, though, is personally my views, like essays and stuff like that. If you give a score, they really focus on the mark. I personally try to avoid giving marks, but focus on giving comments and constructive feedback.
Yeah, the score we give is at the end of the program. We never tell them the score. It's for the supervisor. I mean, the program coordinator is the only person who sees the scoring. And if somebody's score is very low, we pull them out again and give them either intensive training in whichever step they are having problem or whatever is the troubleshooting that's needed. A good point.
Yeah, no, that strikes me. That's very sensible. I like that.
There was a lot of questions on how do you train people on management of PCR during the training program?
This is another blood boiler. It's a bit like saying, orthopedic surgeon, we must break a leg so you can practice setting it. If I drop a nucleus, I don't retrieve it. It goes to the VR surgeon. Nowadays, modern simulators, you'll have to learn simple vitreous loss management on the simulator, hopefully, and very little in practice. And if we reach a stage where complication rates are so low that we hardly ever see a case of vitreous loss, then as now, the idea of the hero surgeon should be gone. You just refer it on to a colleague who's experienced in it. I think it's the idea that every surgeon must be able to handle every complication they have is a historical concept. Certainly, I would never dream of trying to retrieve a dropped nucleus.
Adia sir, any
in our setup, maybe until their second year of residency, it is managed by a senior surgeon. And then we have actually one kind of a workshop for like 2 or 3 days where we teach them how to manage PCR and all that. By that time, they also have enough experience. Once they have that hands-on experience with the animal eyes and also with all the retractors and all that, then we allow them to do it under supervision. So there is a transition we make after 2 years. Till that time, it's all done by the consultant who's there, the same operating room or the next operating room.
I mean, certainly ours get very little practice, thankfully.
Yeah.
Yeah, I think probably there are plenty of videos which are available on YouTube. I think they need to look into them. I think many of us have learned newer techniques by looking into the available videos or going through. One advantage we found during our FACO program is all these FACO fellows had a very good opportunity they get rotated to see all the surgeons, and they also get a chance to be supervised by the best surgeons. So that has really gave them confidence in handling complications and fast learning curve. So
one tip, for picking up the complications and all that early, and also to avoid complications, is also people have to pay attention to the illumination of their microscope and also to use the magnification. I think these two, they don't really pay attention. I think they need to pay attention towards that. So today we have good microscopes, but they should know how to adjust that illumination so that they'll be able to see the PC well.
Yeah, I think we are just running short of time, so we'll go ahead with the Dr. LV ma'am's presentation. Yeah, we'll come back to the session. 2 questions, probably we have time at the end. Thank you, Thank you, Dr. Foss and all the panelists.
Can you see my slides?
Yes, ma'am.
Yes, madam.
Yeah, I'm sorry. I really don't know what happened. I just left the meeting and joined back, and it's working. I'm really sorry about it. And thanks, Rika. And I will be talking on management of a difficult situation, that's an non-ophthalmos, in terms of managing cataract. And non-ophthalmos is a congenital micro-ophthalmos. It's basically a dwarf eye with a reduced eye volume. due to arrest in growth after closure of the embryonic fissure. Many times it can be sporadic, but also it is a autosomal recessive problem. The typical appearance of an anophthalmic patient, you will see a narrow palpebral fissure, deep set eyes, and they will be using aphakic type of glasses. That's a high hyperopic glasses. And they will have family history of angle closure or blindness in the family, especially with the familial autosomal recessive anophthalmos. And ocular features usually characterized by high hyperopia, almost more than 12 diopters of hyperopia, reduced corneal diameter, usually 10 to 10.5 millimeters. Rarely, we don't see often a microcornea. It is only a reduced corneal diameter to maybe 10 to 10.5 millimeter. Very shallow anterior chamber. Axial length can be somewhere from 14 to 20. By definition, any axial length less than 20 millimeters has been considered as an anophthalmos, but the management of the situation varies widely between the lower end of the axial length spectrum and also the higher end of the axial length spectrum. And they will have reduced ocular volume, and one can see wide amplitude of ocular pulse, especially when the ablation pressure is taken. The wide ocular pulse is seen, and they typically will have a thick sclera more than 2 millimeters. And in a small eye, they will have a normal size lens. That's why all the problems happen. Majority of the times, they may have associated posterior segment abnormalities. And on top of it, they have a high propensity for angle closure glaucoma. And usually the glaucoma happens after 40 years of age. Rarely you see high pressures and angle closures before that age. And how do we manage? Most of the times, it is young patients where they need only spectacles. With the age when they develop the glaucoma, the management of the glaucoma becomes important. And the angle closure is mainly due to the crowded anterior segment, and they can also develop uveal effusion leading to secondary angle closure. Why do they develop uveal effusion? Because of the thick sclera, the outflow, that is venous outflow out of the eye, is defective because of the compression of the vertex veins by the thick sclera. And also these eyes, whenever there is a sudden decompression with any form of surgery, can cause uveal effusion. That's why the surgery becomes a challenge when we operate on these individuals. This is a slide that shows a thick sclera resisting the venous outflow, resulting in the choroidal effusion, seen on the picture here, and also seen as an ultrasound. So how do we manage when the angle closure occurs? Usually the PI is done to take care of the pupillary block. Sometimes we may have to resort to the iridoplasty to open up the angle, and the residual raised intraocular pressure is taken care with the medication. Many times the surgery may be needed. It may be just the cataract surgery, and sometimes it may be combined surgeries. So what do we recommend? We do recommend a prophylactic sclerectomies to minimize the chances of the associated complications. We at our institute follow this, what is recommended by Wax and et al. In 1992, where anterior lamellar sclerectomies and sclerotomies are done in 4 quadrants. So the debulking of the sclera will help in reducing the choroidal effusion, mainly because it facilitates venous outflow from the eye. And in contrast to this, people may also do a posterior sclerectomy, where the sclerectomy is much posteriorly located in comparison to the anterior lamellar sclerectomies. It is beyond the equator, along with the vertex vein compression. So then why we are recommending anterior lamellar sclerectomies? It is easier for an anti-segment surgeon to take care of this procedure. I'm presenting one case here, a male of 47-year-old, a decreased vision in both eyes in his childhood. He gave a history of pain and redness and watering in the left eye with a history of IOP of 60 millimeters of mercury in the recent past. He had iridotomy in both eyes. And if you look at his refractive error, he was using plus 16.5 diopter lenses. His vision in the right eye was 6/18 and the left eye it was 6/60. And this is the right eye picture, this is the left eye picture, and his axial length was 15.6 in the right eye and 15.7 in the left eye. And the left eye pressure was 43 millimeters of mercury. And this is the anterior chamber. You can see it is very shallow, and that is the that was the right eye, and this is the left eye. Left eye has even synechiae because of the repeated attacks of the angle closure. And typically, these eyes will have a crowded optic now. This is the right eye, and this is the left eye, and that tells you that it's a very short eye. And this is the A-society showing the 2 millimeter anterior chamber depth in the right eye and 1.98 in the left eye. So what we advised was left eye a phacoemulsification with intraocular lens implantation with a 4-quadrant sclerectomy under general anesthesia. We have chosen general anesthesia because any kind of peribulbar block, because of the short eye and a shallow orbit, can have a positive pressure effect on the eye and likely to increase the complication rate during the surgery. I'm showing the same patient video, which is a little older video, but at the same time, I just want this to be shown because it will give us how to do the sclerectomy. Basically, it involves a 360-degree peritomy with the relaxing incisions and tagging of the 4 recti muscles. After all the 4 recti were tagged, and in each quadrant, a good diathermy is applied to get a vascular bed, and 2 millimeters from the limbus, a 4x4 sclera is defined and dissected. You can see a narrow space between the 2 recti muscles here that tells you how short the eye is. A uniform dissection of the sclera is being done and it is excised. Once it is excised within the bed, we make a V-shaped incision about 1 millimeter by 1 millimeter. It is almost full thickness. And after making this incision, the tip of it will be snipped off. So it is the sclerostomy here. And this debulking and the sclerostomy helps even if there is any effusion later and that gets drained out. The same will be done in 4 quadrants. So tagging the muscle helps in having a good exposure. It is about 2 millimeters from the limbus. After doing the sclerectomy, again a V-shaped sclerotomy with the sclerectomy there. When we snip the tip of the V, you will be having a sclerostomy. This is the 3rd quadrant. And this is the 4th quadrant. So many times once we do this, we do see some deepening happening in the anterior chamber, and preferable to do a scleral tunnel because with the clear corneal incision, there is always a chance for the iris to prolapse because of the crowded anterior segment. And one requires a good viscoelastic, maybe something like a viscoat or Helon. I prefer to use the viscoat. And the removal of the synechiae with either with the spatula or Kuglin hooks. And the routine capsulotomy. Because of the shallow anterior chamber, there can be challenges in doing the capsulotomy, initiated with the needle and completed with the Uttarata. And a routine hydrodissection, and whatever method one is comfortable with, we tend to do the stop and chop. And what is important here is to maintain a good anterior chamber. So you need a good bottle height or a higher intraocular pressure when you're using the newer machines. 40 diopter lens is the maximum power available with the Alcan ACQUISTION. Even though patient needed 56 diopter power, we never had an access for that. So the 40 diopter lens has been placed in the bag. Once the lens is in the bag, most of the problems will be taken care. So leaving a lens in the sulcus is not a good idea. You may not get 40 diopter lens with the 3-piece lens available easily unless you custom made it. So this is the postoperative picture. You can see well-placed intraocular lens, a fairly deepened anterior chamber. You can see central AC is well formed. At end of 6 weeks, patient had 618 vision and with required +8 diopter lens over it, because the lens power what we have given is not exactly suitable to this eye. And nanophthalmus, when there is no cataract, it is usually taken care with iridotomy or iridoplasty, and the intraocular surgery has potential complication. 4-quadrant sclerectomy is what we use routinely, especially in eyes which are in the shorter end of the nanophthalmus. That is anything below 18 diopters. I think it is better to have some kind of a sclerectomy to minimize the chances of the effusion. And before I conclude, I just want to share some of the information we have available, that is especially the publication from this part of the country. And this is a series of 75 children with an anophthalmus published by my colleague Dr. Smita Garkar, who noticed that the narrowness of the angle increases with the age. She found the ratio of the lens thickness to the axial length, when it increases more than 0.239%, 239, it increases the risk of the angle closure by nearly 3 times. So it is important to keep doing the gonioscopy. If they are not able to perform the gonioscopy, maybe biometry may be a useful tool to follow these children with to know whether there is any alteration in the lens thickness to the axial length ratio. What is important is many people will say, is it advisable to remove the lens and implant an intraocular lens to correct the high hyperopic lenses what children are wearing? My suggestion is these eyes are abnormal eyes. Better not to touch them unless it is essential to do a surgery for them. So the question of removing the clear lens doesn't arise in these children. Manage them with the spectacles, manage the narrow angle. As and when they age, depending upon the situation, the lens should be taken care. But touching the eye unnecessarily without indication, one should be prepared to face the possible complications that are often seen with an anophthalmus. The next 2 publications are from Arvind Eye Hospital by my colleague, Dr. Sharmila, who has a large series, and she looked at 60 patients with the nanophthalmus, where she randomized them either to the phacoemulsification or small incision cataract surgery. She noted less complications with the sclerostomy whenever there was a sclerostomy done. Interestingly, they have done the sclerostomy only in the inferior temporal quadrant, and they found even that helped. And they also found the phacoemulsification group has less complication in comparison to the small incision cataract surgery. So there was a question, what kind of IOL DBR formulas people will use? Like any other small eye, I think the Halliday 2 was recommended by many, but I will come to that in the next paper. And she also presented a large series of nanophthalmus patients. So I'm surprised to see it is more than, I think almost 144 patients. They had consecutive subjects with an anophthalmus. And they found that again, doing a phacoemulsification with the sclerostomy was associated with the less number of complications. In both situations, the availability of the required intraocular lens is an issue, and the DBR surface also is an issue. To address this, there is a publication recently in the AJO. It is from Germany, and they also found that the required intraocular lens was 56 and 58 diopters, and they could custom made the intraocular lens. They got a foldable acrylic lenses from a company in Germany where they have used plus 56 and 58. How did they arrive at the plus 56 and 58? They have taken an average of SRKC, Holiday, Higgins, and they have decided this is the lens they needed, because when they looked at individually, it varied from almost from plus 50 to plus 70. When they have averaged it, they got plus 56 and plus 58. And with this, and the patient was almost ametropic. So it is a challenge. So one has to look at the multiple options and take into consideration taking an average of the DBR measurement. And please note, these eyes are very crowded and it's not an advisable to do a piggyback. If somebody really wants to make them ametropic, it is better to custom made intraocular lens rather than to consider the piggyback lenses, because these eyes are really abnormal eyes, and doing as having a as conservative approach as possible is a better option. Thank you very much.
Thank you, ma'am. That was an excellent talk with clear messages. Now, usually for the cataract update, we have questions from the update team for the panel, but this time we had an overwhelming response from the audiences, and a lot of questions, especially for this session, cataract surgery in nanophthalmic eyes. And we'll go directly to the questions by the audience. I've created a PPT. I'll just share my screen with the Is my screen shared?
Yeah.
Yeah. So in this session, the questions I have sorted out based on some people had particular questions about the technique, some had about IOL and biometry, and some had about glaucoma. Probably they realized we have a very good esteemed panel from, we have some glaucoma specialists in our panel. That's why some glaucoma related questions are also there. So first we'll tackle the technique related questions. The audience wants to know what are the issues with cataract surgery in a nanophthalmic eye, in a microphthalmic eye, and an eye with just microcornea. This is what I could gather from these questions. And in all these eyes, how to avoid and deal with intraoperative positive pressure, or what we call a hard eye, and reasons for postoperative refractive surprises that we'll tackle with the next group of questions. And there's a question that if the cataract is very hard, should we proceed with SICS or do a phacosurgery? And some people want to know how to deal with floppy iris. I presume it's with nanophthalmists that they want to know how to deal with the floppy iris. So I would like to know from the panel, the first one, what are the issues with all three situations? Any BS ma'am, LV ma'am, would you like to take
most of the things I have addressed in my talk when in terms of managing the nanophthalmic eye. So we did discuss. I'm not sure what else you want us.
Yeah, everything is, I know, I understand that most of the things were there in the talk. Anything the panel would like to tell? The difference between, probably to begin with, that nanophthalmos has a very peculiar situation where the anterior chamber itself is very crowded when compared to posterior microophthalmos. So the issues of the kind of lenses that you can try putting in these situations, that needs to be addressed, probably, like something about piggyback IOLs, where you want to put something in the bag and then on top of it something in the sulcus. If there is a nanophthalmos, that is you have documented the anterior chamber is very crowded, would you like to go in for that in these eyes? BS ma'am, Dr. Ravindran, Dr. Sri Priya. Anybody would like to add?
Shika, can I say something? I think Dr.
Yes.
Vijaya has very nicely described the preoperative assessment, the intraoperative precautions to be taken, and how to be as safe as possible during the surgery. I think the first thing to say is please don't try clear lens extractions in nanophthalmos in order to correct the refractive error. That should not be the case. The second thing is these are very difficult surgeries to do, and the surgery should be performed by a really experienced surgeon who anticipates all the problems which are likely to occur. And the question of positive pressure in the presence of even if raised intraocular pressure is not present, you have to look for choroidal effusion. If you have a UPM, you can get that assessed, because even with the normal IOP, sometimes these people have choroidal effusion. Ultrasound examination to look for the thickness of the sclera and the choroid, you get an idea whether these patients really have nanophthalmos, the typical nanophthalmos. If the axial length is more than 18 millimeters, it is a little easier to do, but if it is 15, 16 millimeters, as Dr. Vijaya has described, it's extremely difficult to perform the surgery. So unless meticulous attention to detail, as she has shown in her video, is taken into consideration, it's very difficult to get good results. So a proper preoperative assessment, a skilled surgeon, taking all the steps as slowly as possible, making sure that the anesthesia is adequate, taking care during every step is extremely important. If necessary, hyperosmotics can be given prior to the surgery. If general anesthesia is preferable to avoid positive pressure, intraoperative mannitol can be given if you have extensive pressure. In the case of a floppy iris hooks can be placed, and maximum bottle height to be maintained. Make sure that you don't forcefully rotate the nucleus so that you avoid any damage to the zonules. And if the positive pressure is very high, this has happened to me in one situation where I had to do a combined surgery. And there was such high intraoperative pressure that in spite of doing a 4-quadrant scleral resection and full thickness sclerotomy. So in that situation, I just completed the trabeclectomy. I did not put an intraocular lens. I was able to put a secondary IOL in the back of about 3 weeks later. So I think this is important to make sure that you've evaluated the patient completely and taken all the steps required to get as good an outcome as possible. Piggyback lenses in this situation, I don't think is ideal. If you can get a custom-made lens, it would be better. I think piggyback lenses were described more for IOL surprises, and I will leave that to the others to discuss. This is my opinion.
Dr. Ravindran, would you like to tell us something about role of SICS? If the cataract's very hard in these eyes, should anyone opt for SICS than trying phaco?
I mean, there are certain cases where we need to do SICS. So the paper Dr. Vijaya mentioned is where the phaco was or SICS was chosen based on the hardness of the nucleus. So wherever the cataract was mature or advanced nuclear cataract, they've chosen SICS, and the outcomes also, they had more complications in that group. So ideally, I think we need to intervene in these cases much earlier where we can do phaco. So now we are able to do it with like a 2 millimeter or even a smaller incision. We are able to perform phaco, and we have much better control, and that should be the way to go. And all the precautions Dr. Vijay and also Dr. Shanta mentioned. And coming to the piggyback, I think the practice is very varied in Aravind. There are some of our hospitals, some of the surgeons use a piggyback. Others go up to that 40 diopter IOL, which is available standard, and then put it and then correct it with the spectacles. And where they have used, they also have used a piggyback, and in one or two instances they used a custom-made IOLs. The feedback from the group who have used a custom-made IOLs, they say that when it like 50, 55 diopter lenses are very difficult to handle and also to implant. And even injecting them through a regular whatever injector you have at this point of time, 4W is a challenge. And they also feel that the bulkiness of the optic also kind of make the anterior chamber shallow. So they prefer to put one IOL in the back and the other IOL to correct it in the sulcus, a 3-piece which has got a little bit of angulation. So that's the opinion. So even though you can make, we Oral Lab had made this custom-made IOLs and given it to them, they feel that may not be the ideal way to go. So they feel that piggyback IOLs is better. So recently they put one 68 diopter. They put a 40 diopter. I think 63. They put a 23 diopter in the sulcus. They feel that results are good.
So in these
you want
cases,
to say something about your experience, Ashish?
No. The custom-made IOL of 50.
No, sir. I think Ashish had one case where with the piggyback what happened. So I just want people to be aware of possible problems with the piggyback.
Yes, sure.
Yeah, so we had actually the axial length of that patient was around 16. So, and the IOL power was around 50 diopters. So we put in a 34 diopter in the bag and a 16 diopter in the sulcus. So unfortunately, the patient came back with the malignant glaucoma about 3 weeks later, and the whole IOL had rotated. So we had to remove the IOL and then do a vitrectomy. So after that, we realized that piggyback lenses are not a very good idea. And secondly, when it comes to the doing a sclerectomy, I think so the axial length and the RCS complex thickness are very important. So we decide from that in which patient we are going to do a sclerectomy or not. And routinely we give a mannitol to all patients, and a prophylactic PI is done before surgery. And we have also had a lot of experience. We published a study on microcornea and colobomas. We get, for reasons unknown, we get a lot of colobomas here. And one thing in coloboma is that the cataract is very hard in spite of patients being very young. And so there's always a dilemma seeing the corneal size, whether we should go through the anterior route or the posterior route. So we always decide based on the corneal size. If the corneal size is too small, then we go through the pars plana, and the vitreoretina surgeons, they complete the surgery and leave the patient aphakic. And if the corneal size is good enough, then we go through the anterior route. And of course, the decision to do a phaco or SICS again depends on the
what is the cutoff that you take, Ashish? What is the cutoff of the corneal size?
Generally, corneas which are around 7x7 and more than that, we do through the anterior route, and less than that we ask the vitreoretina colleagues to do it.
Shikha, a nanophthalmus you don't see a microcornea. So the cornea is smaller. It may be 10 to 10.5 millimeters. A microcornea is altogether a different entity. You may see them with the colobomas. So the picture is totally different from the nanophthalmus. Microcornea can still have a normal axial length, whereas a nanophthalmus, I've never seen anybody with a microcornea that is 7 or 6 millimeters with a nanophthalmus.
So microcornea will have a normal lens bag. So a normal IOL can go and it will just...
Even nanophthalmus will have a normal lens size. The dimensions of the lens is normal in a nanophthalmus. Eye is small in every way except the lens.
And in microcornea, there is no crowding of the anterior chamber. There's no crowding of the anterior chamber. The issue is the logistics of doing the surgery through a very small cornea anteriorly. Whereas in nanophthalmus, there is a whole chapter of angle closure glaucoma that's always there with it, along with choroidal effusion. And thirdly, the what is called posterior microophthalmus, where the anterior chamber is completely untouched. It's almost like microcornea, where there is no crowding of the anterior chamber. So there, probably we can be, we can be more putting these thicker lenses and two lenses. The situation can be a little more forgiving. But these are the things which can be, I guess, studied well if we do the UBM or anterior segment OCT along with the axial length. We need to understand before taking up these eyes. And there was a question about the IOL role of white to white diameter in IOL part, deciding about the size of the IOL. I think Dr. Nivedita has asked. I'll just share my screen once again.
No, again, I think the lens is normal dimensions in the nanophthalmus. Putting the standard foldable lens into the bag is perfectly all right with the nanophthalmus.
So the second set of questions regarding the IOL and biometry is one set of people are asking which formula that already LV ma'am has covered in her talk, that we have to kind of take an average. We'll also take the other panelists' opinion regarding that. And some people want to know exactly which IOL to put. They want the name of the IOL and also from where to get these special IOLs. And piggyback we have already covered, and role of white to white, that also has been covered. So we'll take the other panelists' opinion regarding all these points as well. Anything, which IOL in particular?
I think Alcon is the only one which has IOLs up to 40 diopters. I don't think any other company
I think
has.
Arolab also has, and they're also making the custom made. That's what Dr. Ravindran is.
Okay.
Acrylic lenses, sir. They are all acrylic, sir.
Yeah, they're acrylic. Hydrophobic they can make, and also hydrophilic they make. Yeah.
What is the highest
You said
ready-made lenses up to 40 diopters you have?
No, recently they made something for 53 or 54 diopters.
That was custom made.
Custom made.
Okay.
And otherwise, I think the normal range is up to 30 diopters.
Okay, I think.
Yeah, only as you said, in Acris has got up to 40 diopters. And where they make this custom made IOL is often for toric IOL. Somebody has got 10 diopters, 16 diopters, 15 diopters. Toric they make. So more than I think that most of the people prefer the picky bag than going for this custom made 50 plus or 60 plus IOLs.
The one publication from the Germany, they used the Lensex.
Yeah.
And then they completed the surgery. They didn't do the sclerostomy.
Okay.
And for them, it was a custom made foldable acrylic lens from a German company. I don't know how they could manage in a 15 diameter axial, 15 millimeter axial length without the sclerostomy, putting the 56 foldable lens. And I don't know whether doing few steps with the Lensex has helped them. They had difficulty in docking the device because they felt it is a small eye. But they managed, and the post-operative no refractive surprises.
Apparently, one of the issues is the aberrations associated with custom-made lenses, because that is one of the issues.
Yeah.
For the piggyback, basically the IOL power calculation formula, it's just the same, I guess.
No, I think for shorter eyes, we do the Huffer Q. But when you look at the whatever little publications they have, I think Arvind people, even though they use the Huffer Q, they had quite a bit of surprises. I think the German publisher, that's only just one patient, 2 eyes. Yeah. They have taken the average. If you look at the IOL power for the same patient, it varied from plus 50 to plus 70, depending upon which formula they were using. So they have taken the average of it, and they felt they came out with a good solution, and patient had almost close to ametropia. So I'm not sure with this experience how we can advise someone to follow this.
Dr. Ravindran, at Arvind Eye Hospital, this clear lens extraction to prevent glaucoma is being done for nanophthalmic eyes?
Forget about clear lens extraction in nanophthalmus. Even by mistake, don't convey that to anyone. People are waiting to touch the eyes, and these eyes are not meant to be handled with the clear lens extraction.
Should it be used
of the hyperopia?
Should it be used as a refractive surgery in a young patient with a high thick glasses, high hyperopes? Should it be used just to remove the glasses, you know?
You want to put 50 lens, 56 lens for IOL in a young patient with a clear lens removal? I think that is disastrous, Shika.
Yeah.
I think we should not send wrong messages to people who are listening all over.
Shall I
want...
Shika, can I add a point? Yeah, when we remove the lens, the eye becomes more hyperopic. So the eye is already hyperopic, and if we remove the clear lens, it is the nanophthalmic power, which is about 35 or 40, is going to be 55. So we are going to make it more hyperopic by removing a clear lens extraction. So that's not
obviously with an IOL insertion that is planned. Obviously with a custom-made IOL. But yeah, I want to send across the message of big institute heads, glaucoma heads, institute heads, their opinion.
Glaucoma, it is a question of ethical practice of ophthalmology, Shika. I think we should not be
there is,
like this and giving wrong messages.
Even my
Dr. Ravindra, what do you say?
Yeah, I think Shika is trying to say what you are saying. I think she's saying that we should not be doing it. Just the point Dr. Vijay also mentioned about the randomized trial they did for patients with and without sclerostomy. I think even with phaco, I think the complication rate was around 17%. So I think even with the clear lens, it is going to be very high. I think we should not touch these eyes. Yeah.
Yeah. So when I went through the questions for this session, what I realized is people want to do the surgery. What they want to know is how to get the lens. How to get the lens, and it's not about doing the surgeries in cataract size. It's about many of them want to do it as a refractive procedure. You know, if only we could get hold of the lens, and you know, so what I'm trying to get at is that this is a pathological eye.
Yeah.
And it has its own implications if you touch the eye.
Yeah. And also it is not, I mean, in Arvind, they are saying it so many because it is an institute. In a general routine practice, I doubt even if they see 1 or 2 cases in their whole practice, their lifetime practice.
Yeah.
So I think they should leave these eyes to institutes, if you ask me, for the safety of the patient. And if they're willing to do it, I think they have to explain very clearly to the patient what are the complications going to arise.
So once the cataract sets in, it's not that we should let it grow very mature.
Yes.
Once the cataract sets in, it's amenable to surgery.
I think Dharmila's paper, they do conclude saying that once the cataract sets in, try to handle the patient early with the phacoemulsification with the sclerostomy to minimize the chances of the complications rather than to allow it to become very dense. Maybe I think with the time, the piggyback lenses, what are being practiced now in Arvind, maybe we will get an answer. What are the eyes likely to do well with the piggyback? What are the eyes likely to have the complications? With the time, we will get an answer for that. Till that time, try to refer these patients to an institute. Let the patients be taken care well by people with more experience.
I think it's also important to realize that there is a spectrum. It varies from 15 millimeters to 20 millimeters. 18 to 20 millimeters will be fairly easy to perform, but not 15 to 18. It's very difficult. I've had a patient who was recently referred to Nethralaya following clear lens extraction for nanophthalmus. This gentleman was around 25 years old. One eye fortunately went off well, but the fellow eye, which was operated about 2 weeks later, developed a suprachoroidal hemorrhage. It took almost 2 to 3 weeks for the lysis to occur, and Dr. Pramod Bende did the surgery. Fortunately, the eye is doing well. So that's a devastating complication. So we cannot overemphasize that clear lens extraction in this situation is not a...
One more thing, Shika, all these things can occur in the post-operative period. So people shouldn't go by just what happens intra-op. They may have a successful outcome and finish the surgery, but the post-operative period, spontaneous choroidal effusion occurs, hemorrhagic choroidal effusion occurs. So we have to monitor the patient post-operatively and be in a position to handle the complications. So that is many times not known. And sometimes when they have the posterior microphthalmos, they say that the axial length is overall short and the IOL power is very high. So they think they are operating on anophthalmic eyes, and they put piggyback lenses, and the actual surgeon does not see the postoperative course of the patient. So you may have false information, and the person watching the surgeries also does not know that they don't know the postoperative course of that particular eye.
And also, in young people, when you remove the cataract, the accommodation is gone. Okay, and when we handle a clear lens, the chances of the posterior cortical opacification with the time is much higher, because it's impossible to clean the entire capsule of all those cells. So again, the problem of handling the posterior caps, the opacification, all those things will come back. And when we put only 40 diopter lens in the eye, if you are not putting a customized IOL or not doing the piggyback in what Arvind people are doing, again, patient will be having +8 to +7 lenses. In what way we are able to take out the glasses? We cannot guarantee patient will be without the glasses. So there is a need for the glasses over whatever power we are implanting inside the eye. And very important to maintain the rexis, because this 40 diopter maximum available with Alcan is a square-edge single piece lens. It cannot be placed in the sulcus. So we have to do a good surgery, make sure that the bag is intact and the lens has to go into the bag.
Shika, I need to here. I think we are running short of time, so we should switch over to the...
Sure. We had an excellent discussion and an excellent talk. With that, we'll move on to the next talk.
Intentions were to send the good message, Shika, nothing else. Thank you.
No, it was a nice discussion. Thank you. Vijaya's presentation was really nice.
Thank you.
Excellent talk.
Thank you.
I mean, first time we are discussing about anophthalmos in a webinar.
That's nice.
And it's about cataract surgery. I don't think any other group has discussed it. That way it's good. I think people should know about it.
Thank you.
Yeah, thank you.
Thank you, ma'am. Yes.
Sudhir, you would like to?
Yeah, I'd like to introduce Dr. Ashish Bajaj. Ashish is a senior consultant working in the cataract and IOL services at Sadguru Netra Chikitsalaya in Chitrakoot. He's also done a fellowship from Advanced Cataract Surgery and FACO fellowship from Shankar Netralaya. He's also heads the quality assurance and he's responsible for implementing quality policies and in charge for NABH accreditation at SNC. And he's also a member of working group for formulating eye care protocols for Orbis partner high hospitals during COVID pandemic. We welcome Ashish to this session, and he's going to talk to us on cataract surgery in community ophthalmology setting and how to optimize the resources for enhanced services. Dr. Ashish, please go ahead.
Thank you, Dr. Sudeep. Thank you for your kind words. I'll just be sharing my screen. Is my screen visible?
It's visible, Ashish.
Yeah. So thank you so much, Dr. Sudhir. At the outset, I'd like to thank the organizing committee of Shankar Netralaya and Dr. Shikha and Dr. Sudhir for giving me an opportunity to be a part of this webinar. So my talk basically is going to be...
Ashish, before I interfere, can you go to display settings as duplicate settings? Because go to display settings on the, slide,
On the top, yeah.
On the top.
On the top,
Just change it.
Click on that. Yeah, duplicate. Duplicate, yes.
All right. So is it visible now?
Yes.
Yeah. Now it's fine.
Yeah. So I'll be speaking about how to have a sustained model of community ophthalmology, having a high volume and high quality setup within the rural and remote area. And basically, I'll be talking about the model which we follow. So when it comes to my presentation, I'll be just talking about the background of our organization and how we have transformed over the years and what took to get this transformation. And then I'll talk a little bit about quality assurance and finally, what the key message this presentation has. So to begin with, it was the year 1950 when the first eye camp was organized in Chitrakoot by our founder, Param Pujya Gurudev. And at that time, there was no electricity, there were no basic amenities. In spite of that, it was able to do 950 cataract surgeries at that time. And we realized that there was a huge rural disparity in the area, and being rurally located with minimum facilities available, it was a challenge to sustain this sort of eye surgeries. So initial days of the journey, as you can see, it was a difficult road with no road connectivity, no basic amenities. And as they say, that difficult roads often lead to beautiful destinations. So we were able to sustain and go where we are today. So this is, as I told, that basic amenities did not exist at that time. And it was a great concern that how this is going to sustain. So there were a lot of roadblocks which prevented from going further because there was no skilled manpower. There was only, all of the people who were working were volunteers. There was no professional education system to get the required skilled manpower, the allied paramedic staff. There was no financial viability because we were only dependent on donors. And of course, there was a lack of management and technology support also to go with all these roadblocks and barriers. So how the transformation has occurred now? So it's been a 70-year journey from where we moved from 1950 to a tent-based camps and seasonal work only occurring in winters to the present, that is 2020, where we are functioning. So this Sadhguru Seva Sangh Trust was formulated in 1968 as a formal trust with the main vision of service to humanity and a mission. Out of the 3 missions, one of them was to give sight for the blind. So this is what the key activities our trust is carrying out. Apart from healthcare and eye care, we also focus on education in rural areas, women empowerment, dairy and agriculture, and a lot of social activities. And these social activities have been evident during the COVID-19 pandemic as well, where a lot of relief work has been done by the organization locally. So over the years, if you see, from 1968, we were a tent-based seasonal camp organization having temporary seasonal eye care. Moving on to 2000, we came up with a permanent eye care facility which focused mainly on cataract surgery. And to present, that is in 2015, we came up with a tertiary eye care hospital which had all the facilities, including subspecialty work. So at present, we are one of the world's largest rural eye hospital, and I will be backing it up with the data why we say that we are the world's largest rural eye hospital with the latest facilities. The population we serve is close to 1 million patients. Every year they visit the facility, and we've got 2 more hospitals. One we have recently acquired in Bareilly and another one in Anandpur. So cumulatively, we are looking at 1 million patients alone in our hospital. And if we add to those 2 hospitals, it's another 0.4 million which we are looking at. When it comes to cataract surgery, we do the most number of cataract surgeries annually. This is, I'm talking about based on a single hospital data in 2018-19. And since the last 8 years, we have been doing more than 100,000 cataract surgeries every year. One of the exceptional identity we have is that we have got a team of 100+ ophthalmologists in a rural and remote place. And considering the fact that it is difficult to retain skilled manpower, especially doctors in such a remote place, this is a big achievement. And this is cumulatively more than the total ophthalmologists which Sri Lanka has. You've got state-of-the-art infrastructure, one of the largest IoT complexes in the world, because what we believe is that if you want to give quality services to the patient, you have to have the best in business, and this OT is at par with the JCI standards, and our NABH accreditation is under process. Now, in order to cater to the different needs, we have got different models. We've got a base hospital approach. We also have outreach, which gives us the bulk of our patients. And we have got a network of vision centers because we realize that the outreach is a temporary sort of arrangement, and the patients, they need to have eye services at their doorstep. We also have come up with the concept of city centers, which help us in following up the patients and give basic services to the patients. This eye care network, what we are today is we serve close to 1.4 million patients, 2.2 million surgeries yearly. and conduct almost 4,000 rural outreach camps. Our hospital network, if you see today, we have 3 state-of-the-art hospitals. One is the Chitrakoot Center, one we have in Anandpur in Madhya Pradesh, and recently the hospital which I was talking in the previous slide acquired at Bareilly, which we are managing. Our outreach network comprises of around 4,000 rural outreach camps, which are conducted across 35 most backward districts of Uttar Pradesh and Madhya Pradesh. And this is possible only with a lot of teamwork and a lot of community engagement that we are able to do this. Now, when we talk of such a large organization, the data and numbers are very important. So if you can see the total outpatients which we have seen starting 2002 and to present, it has almost gone up 10 times, and we have seen about 9.2 million outpatients in about 18 years time. Similarly, if you look at the surgeries, close to 1.6 million surgeries have been conducted in 18 years, which has shown a sharp jump every year. And when it comes to cataract, we almost done 1.4 million cataract surgeries. And since the last 8 years as a single hospital, we've been doing more than 1,000 cataract surgeries annually. And we only do not specialize in cataract. We also have a comprehensive or holistic approach to eye care. And we have all the subspecialty departments and do close to 6,000 retina surgeries annually as well. These are the stable and commendable growth which you can see over the years, how we have fared in all the subspecialties. The service delivery across these roughly 40 years, 50 years has been commendable, and we've been able to serve a large number of outpatients and have conducted close to 2 million surgeries. From being a winter-based eye camp organizer to the state-of-the-art high-volume center, what we are today in 2020, how this transformation was possible. So basically, I will be covering this part of the presentation in how we have optimized our resources, what has been done to look after the training part, and how we have been taking care of the quality assurance. So since we perform close to 800 to 1,000 surgeries, a lot of resources are required. We need trained manpower, and not only doing high volume is important, we also need to give good quality to the patients. So this is how a day at Sadhguru generally looks. Close to 4,000 patients visit the facility along with their companions. We perform close to 1,000 surgeries, patient access to almost 61 vision centers, that is patients who are unable to visit the facility here, and close to 24 outreach camps are conducted daily. Apart from this, there are academic sessions for the ophthalmologists as well as the paramedical students. So what drives us to achieve this? As our director always says, that is the patient first, and if the patient is happy, everyone is happy, and we need to give an accessible and affordable care to all patients irrespective of their ability to pay, assuring quality along with this. So the major challenges what we faced were a lack of supportive environment, because remote locations, there's a lot of trouble reaching there with no good road connectivity, and also generation of human resources. So overcoming the challenges, one of the major challenges was having a sustainable and good human resources. Apart from that, there was also concerns regarding quality improvement and the documentation part. So how we have optimized our resources? One of the most important things I would like to emphasize here is that from one full-time ophthalmologist in 1970 to present, we have almost 100 plus well-trained ophthalmologists, out of which 24 are consultants, and rest we have a team of fellows and DNB students. So what keeps these ophthalmologists or doctors engaged is the 3 aspects, that is a social security, the financial security, as well as the academic security. So the financial security, the doctors are paid at par with the best in the industry, and there is a lot of scope for academic growth when it comes to attending CMEs and conferences. Another important aspect is the generation of skilled manpower, and community engagement is very important in this. So we've got a Sadhguru Institute of Nursing and Paramedical Sciences, where we have got BSc nursing courses, GNM courses, and ophthalmic assistant and VCT courses. So this helps us to generate manpower, and 30% of the work done in the wards, whether it wards, OPD and OT assistants, is managed by these students. Again, paramedical staff, we have devised a mechanism to ensure that we take in people from the local talent pool. They are groomed as eye care professionals and they have a fixed career path within the organization. We also have a Sadhguru Institute of Computer Studies to generate human resources for our information and technology department, because we know that having good data capturing and having monitoring of your services is very important. So we get a lot of support for managerial and IT human resources from the institute. So presently we have a team of around 1,000 employees. Apart from the ophthalmologists, we have got paramedical staff, technical staff, and support staff. And all this is possible because we are able to retain the employees from within the community and have a defined career for them. Community engagement again is very important, and we take pride in saying that a lot of volunteers from the local areas, they participate in organizing outreach camps, and this is one of the co-sponsors meet which you can see in this slide, and this is done on an annual basis. Then once the HR is taken care of, there are a lot of challenges regarding infrastructure and facilities. So we have modulated our facilities in such a way so as to cater a large number of patients which are visiting the facility daily. We have got 25 modular OTs, out of which 20 are dedicated to the cataract surgery alone. We have 6 cataract wards with a bed strength of almost 250 each. So one ward can be managed with lesser number of people, because if you have less wards with less bed strength, you might be needing the same number of employees. Another thing is that whole of the pre-operative examination of outreach is done under one roof. So this results in smooth flow of patients, and work can be done in a more smooth manner and a quick manner. Then comes the financial stability. Financial stability is again a challenge, because initially when the organization started off, we were only dependent on donors. But as our work progressed, we realized to have operational stability as well. So we have a segmented price system here, which includes the free, subsidized, paid, and premium OPD. And as our director always says, that this is equivalent to a railway model where the engine remains the same. That is, the facilities, infrastructure, whether it's the OT, the wards, the consumables, they remain the same. But the customers who are traveling are different. It may be a premium patient, which is equivalent to a first AC patient in the railways, or it may be a free patient. The only difference between the railway model and this is that there is no free bogie in railways, whereas we have got a free bogie where we are concentrating the majority of our work, and the subsidized as well as the paid and premium patients help to have an operational sustainability. In order to, and this is an example of how you can have an operational excellence along with operational sustainability. So you can see that although most of the patients are free, but we've got a sizable number of subsidized and paid patients which can look after the costs of the free patients. Also, financial sustainability is equivalent to self-reliance. So during one of our days, we realized that during the half day, we did not have drapes to carry out our surgeries, and being a remote area, the drapes could not come in time. So we realized that we need to have our own manufacturing unit. So we have got a Mahila Samiti where women empowerment is carried out, and we are doing local manufacturing of drapes, gowns, PPE kits, etc. And this pandemic has even taught us more importance of PPE kits, and even now masks and the PPE kits worn for general anesthesia are being manufactured there. Now, how do we maximize surgeries? So we have got 20 hours dedicated to cataract alone. So we've divided it into 2 sessions. The first session of 5 hours mainly is done by senior surgeons and fellows to take out major bulk of the surgery. The second session of 3 hours is dedicated for junior fellows and supervised surgery and training. So this is how we maximize the time for our surgeries. We have got a separate OT for complicated surgeries, and one senior surgeon is available at all times to manage complications. Across all surgeons, there is a standardization of surgical steps so that it is easier for the assistants to carry out the surgery. I will just be sharing one video of a quick surgery. I'm sorry for the interruption. I think so it's not playing.
If you have the video, directly you can play that. The
Yes.
folder. Yeah, the
Ashish, you
folder.
can go to the folder and play it directly.
Yeah.
Is it visible now, sir?
Not visible. Only the slides are visible, not the video. Video you may have to share again. If you have not shared the screen, then you have to go back and share.
Is it visible now, sir?
No, not yet.
It's
Ashish,
visible
you
to
have
me.
to go to the share screen and select the video and then do it.
Yeah.
I'm sorry, apologize for the...
Ashish, you have to stop sharing, go to the, again, come back to the video.
Yeah, sorry.
Ashish, you have to stop sharing and come back again.
Sorry, I'll... Is the screen share visible now? The slides? I will show the video at the end. It's okay.
Okay. Yeah, go ahead.
I apologize for the...
Please go ahead. Again, go back to duplicate. Yeah.
Yeah, sure. So I apologize for the delay. I'll just show the... So what two steps which we follow are, we don't do a scleral bed cautery, and we are also implanting the IOL as the experience increases under balanced salt solution. So this cuts in the time for a visco wash. We also have a fellows and postgraduate training program, which is important in generating skilled manpower to carry out so many surgeries. And as was discussed, we teach in a graded manner. We also have a National Board of Examinations, and International Council of Ophthalmology fellows also visit our institute to gain more experience. Our fellowships are also certified by the top university in Madhya Pradesh. And in order to carry out the training and development, we have one of the most advanced wet labs supported by 3D systems and a resource center. Now coming to, once we've taken care of the resources, it's not only the numbers which matter, but also you need to have a quality assurance program and how you monitor the quality within the organization. So there's a systematic patient flow within the organization. This helps in smooth and good quality work within the organization. Everybody is aware of their role. This continuous training that is being done. And right from the start of the surgery to the discharge, it's taken care to have the safety of the patient is kept in mind the foremost. We have a safe surgery protocol. We follow the 4 international patient safety goal, that is the right patient, right site, right procedure, and in addition to that, the right IOL power, and a 4-point check is there to identify the site and the patient along with the implant power. This is how we monitor our safe surgery protocols at the level of the OPD, the ward, and the OT. We have prepared our own cataract surgery safety checklist so that the errors are minimized or nullified. Also, as far as procedures are concerned, we have got different color-coded sheets for the different departments. We are also in the process of now acquiring EMR, and shortly it will be functional. We also strive for continuous quality improvement, and in the early 2000s, you can see that we had a long OT with a lot of tables within that, and we've come a long way from that. In 2015, we have started with the 25 modular OTs, which are dedicated for different types of surgeries, out of which the majority of them are for cataract. When it comes to the prevention of surgical site infections, the OT infrastructure is such that OT is being modular. There is a zoning of OTs. We have a unidirectional flow of patients and material so that there is no mix-up between the sterile and non-sterile material. Continuous training is given to the staff regarding these aspects and how to prevent surgical site infections. The OT layout, all the OTs have got a HEPA filter and a pass box. So this helps us to prevent the infections, and our infection rates is one of the lowest. In standard practices, when it comes to the OT, the employees or the people working here are trained across for the standard practices, and they are same for all types of surgeries. As is evident, we use double gloves, outer glove being changed after every case. The gown is changed after every 5 cases. And most important is that we are using intracameral moxifloxacin for all our cases, whether it's phaco, SICS, whether they are paid patients or free patients. And we also document the culture of all the consumables which are being used intracamerally, and we preserve the 1 bottle of BSS and viscoelastic when we open a new batch, so as to trace if any, in case any adverse event occurs. So these are some of the OT practices. Povidone iodine post-block is instilled in all patients. We're also using autoclaved BSS, and we use a fresh set of blades for all patients. We do not ETO them and do not reuse them. Again, OT disinfection and surveillance is according to the standard protocols. What we are following, we do an air culture every 15 days and a swab for microbiological examination every 7 days. Strict asepsis and cleaning procedures are followed, which are at par with the existing guidelines. OT surveillance is done with a lot of care. We do a water culture for the OTs once a month. Air culture is done, and a yearly HEPA filter cleaning is done. This is also supported by a well-established CSSD. You've got large CSSD having 3 double-door autoclaves. You've got a ETO sterilizer and a plasma sterilizer as well. For cleaning of instruments, you've got a distilled water plant within the CSSD itself. So this is a very important part of instrument cleaning. Flow of material, when it comes within the CSD, there's a unidirectional flow of material from clean area to a dirty area. And we have also got a separate dirty corridor and an unsterile lift. So this prevents from mixing up of the contaminated laundry as well as the instruments which have already been used with the autoclaved instruments. The CSSD practices again are standardized. We do all the indicators which are recommended, and there is a strict protocol for instrument cleaning and packing, right from cleaning to ultrasonic cleaning, drying and packing. There's a fixed protocol. And since we do so many surgeries a day, we've got a large reserve of instruments, close to 800 sets, which 800 sets for cataract surgery alone in order to take care of the high volume of surgeries within the organization. We're also keeping it up with the accreditation requirements which are in place, and in the industry we have already got an ISO certification, and we have applied for an NABH accreditation, which shortly we will be acquiring. Then when it comes to the quality alone is not essential. We need to do a quality monitoring as well. So if you see the post-op visual outcomes, our visual outcomes are within line with the current WHO standards, and the follow-up rate for surgeries for post-cataract surgery is almost 89%. This is assured because of a good vision center backup, and most of the patients who cannot come back to the base hospital, they are advised to follow up at the vision centers. And we have also got fixed review camps, so where the patients, they come once the post-op follow-up is to be completed. Again, we have got a good way of monitoring surgical complications. All the complications are documented within the case sheet, and there is a software-based method of capturing complications. They're also captured surgeon-wise, and if a surgeon is having a lot of complications, then we do hand-holding, and we've got a Sadhguru Alcon Learning Center and a wet lab which has got the latest equipment, and they can upgrade their skills within the wet lab. Again, surgical site infections is an important part, because if you're not delivering quality to the patients, you are not going to get satisfied patients. So we have got an hospital infection control committee which monitors the infections and makes guidelines for controlling infections within the hospital. Our endophthalmitis rate is well below what is the recommended rate. And when it comes to satisfaction, we always take a patient feedback, and if the patients are satisfied, the hospital itself is satisfied as a whole. So patient feedbacks and surveys are conducted regularly, whether it's over the telephone, whether it's through the forms which are available with the counselors. We also got registers where the patients, they can put down their experiences. Now, another important thing is that how we are going to manage outreach in the COVID era, because there is a big, we need to do so many surgeries, but we are not able to get outreach at present because of the Government of India norms. And there are going to be other challenges because patients will not travel. There are government norms requiring social distancing. So the solution which we have come up with is getting patients through vision centers. Here, the teams at outreach, they have gone to the vision centers and then they are doing screening, and then the patient, they come to the hospital on their own. So we've got a network of 61 vision centers which are helping us to overcome this situation. So key message, what I would like to convey here is that the problem in the rural areas is an accessible and affordable quality eye care. The solution is to develop a comprehensive rural eye care centers with all the facilities. The Chitrakoot model remains an example of how we can provide good quality, high volume eye care in rural areas and inaccessible areas without compromising on quality. We can have a financial and operational sustainability simultaneously and also deliver quality work to the patients. So key focus areas to sustain such a model is patient satisfaction. The patient remains at the top. Employee engagement, getting employees from within the community, quality, strong quality assurance and monitoring, and striving to continuously improve. And the journey of quality and high volume, high quality care continues. Thank you so much for your patient hearing.
Thank you, Ashish. It was wonderful. It's a great transformation to see the changes that you have shown from 1950 to the current over the 70 years, and it's commendable to see high volume surgeries and high quality surgeries. I will come back to you again with questions, and I request Dr. Girish to give his opinion on how to maximize the resources in a community setting and what model will be the best model, like in the financial sustainability model.
Ashish, could
Yeah, sorry, I'll just stop.
Dr. Girish?
Ashish has to stop sharing the slides.
Ashish, share
Yeah,
screen.
I've stopped sharing. Yes.
Yeah, Dr. Girish.
At the outset, I'd like to congratulate Ashish and the entire team of the SNC. I think the work that they are doing is outstanding, and it's mind-blowing the numbers that they are able to achieve, and assuring the kind of quality. It's not just achieving the numbers, but also delivering on all the parameters which make it as a successful outcome. I think it's tremendous, and on behalf of all the participants and from Shankar Nethralaya, kudos to the entire team and the management at SNC for the outstanding work that has been done. I think I really don't need to say anything more. I think what they are doing is tremendous. So if everyone has followed what Ashish and his team have been doing, I think that's probably the most successful model. So I think it's kind of a supply chain. So you have centers, the vision centers, which are right at the doorsteps of the patients, and then you guide the patient up the chain, the secondary centers and the tertiary centers, and this is a model which has worked very well for them, and probably in this COVID time, this is the one which actually would be helpful, because as he said, camp activities are restricted. Now the government, the Ministry of Family Welfare has relaxed the norms, saying that you can have camps up to 100. So previously where the camps are totally stopped, now it can be possible. But we also know that, especially if people come to know that Arvind or LV Prasad or a Chitrakoot or a Shankar Nethralaya is holding a camp, people will come in hordes. And more so because for the last 6 months, there was a lockdown. So it's very difficult to control this crowd. And obviously, once we have this exposure, the chances of COVID spread from these becoming super spread events is very likely. So the only way to control that is to divert these patients to these vision centers and then, gradually move them up. I'm sure Chitrakoot or Arvind may not be still achieving the kind of numbers which on a normal working day, 800 plus, 1000 plus, they are achieving, but still they would be doing much better than other organizations which purely depend on CAM-based activities. So for Shankar Netale, I think what is probably different is the MISU, where I'm sure Rajesh will be able to put more light on this. So the MISU activity is something which is entirely different from what is being followed at either Arvind or Chitrakoot, where we reach out to the patient in their community. So it's still manageable to have these patients within the norms of 100, and where we have a little more controlled environment and do the surgeries over a period of 2 weeks and get back. So that's also a model. But ultimately, the only way to make a self-sustaining model is either to depend on donations to take care of some of the overheads, or have a model in such a way that your internal accruals take care of the free surgeries. So you have a combination of paid, concessional as well as free surgeries in such a way, get a proportion that your internal accruals can take care, and that's probably the only sustainable way. Because now with the COVID, even the corporates are finding it difficult to sustain their CSR activity. Most of them are diverting their CSR funds to the PM COVID fund, which is probably the need of the hour. So obviously, the near future would be a little tough for organizations which purely depend on funding from the corporates. So you need to find out a model where you reach out to individual donors, philanthropists, and also look at ways of cutting some of the wasteful expenditures. So I think it's a combination of all of these which will make the organization self-sustained for the next 6 months to a year. I think that will probably be the time before we actually reach some amount of pre-COVID normalcy.
Thank you, Dr. Girish. I think that's good points you have added. I think I will come back. I'll hand over to Rajesh to just highlight on the how the MISU. I think this is the only hospital, the operation theater on wheels in India. I think given the COVID situation, I think we can take the MISU will be a more ideal model where the camp and everything can be done in the local place. So the travel to the base centers, which will be much absolutely not there. So Rajesh, can you highlight briefly on the MISU? Yeah.
Thank you, Dr. Sudhir. And MISU is functioning in 2 states in India, one in Tamil Nadu and one in the state of Jharkhand. And where the 2 buses have been modified into a functional operation theater, which can travel to any location, mainly the rural and tribal area, and that will be parked parallel and will be connected with an interconnecting vestibule. And a camp usually will be notified with the request of local authorities, and it will be for 10 days after getting permission from the TBCS. And then the 2 buses, along with a team of 20 people with the instruments for the ophthalmic evaluation, will be reaching the location, and the buses will be parked in a plain ground, and it will be connected with the vestibule. In the meantime, in a nearby fixed facility, the outpatient will be set up with the instruments, and the buses will be cleaned and sterilized, and the swabs will be taken by settle plate method and by the particulate count for 3 days consecutively, and it will be ready once the 3 consecutive swabs will be negative for culture. In the meantime, patient has been examined and are selected for the cataract surgery, and by 4th day, mostly the swabs will be negative and the surgeries will be started. And on a day, on an average, 30 surgeries will be done. There will be 1 operating surgeon on the board, along with the other team members for the OT staff, OPD, maintenance, and we do EMR for the MISU also, for both the OPD as well as the inpatient for surgeries. And the patients are local patients who will be examined and will be given the date to come, on which day of the surgery to come, and they'll be going back after the surgery. and they'll come on next day for the first post-op, and after a week for the second post-op. And the camp usually will be finished by 10 days, and on 10th day, after seeing the second post-op, the entire team and the buses will return back to the main hospital. And for the people who have not been seen by for second post-op will be seen after a week by a doctor, ophthalmologist, and 2 assistants going back to the same place. And after a month, again, that time the refraction is done and the spectacles are distributed at a later date. This is how a MESU activity is conducted, and this is done in Tamil Nadu as well as the adjoining district of Andhra Pradesh and in Jharkhand.
Thank you, Rajesh. I request Dr. Adia sir to add upon the model which Arvind follows with the high volume surgeries and how they optimize on the resources.
It's similar to what Dr. Ashish spoke. We have the same model of outreach eye camps, and also we work on vision centers. And almost whatever the process he explained is what we also follow. And it's also very gratifying to see how the way Chitrakoot has grown in the last 20 years. We've been kind of closely working with them, following them. And it's a phenomenal transformation. I mean, it's an example, you know, if you have a larger vision and if you have selfless work and with the divine grace, you know, what you can achieve. And in a rural area like this. And he was also aptly saying that, you know, the number of surgeons they are able to have is much more than what they have in whole of Sri Lanka. And to have so many doctors in that place is mind-boggling, and it doesn't happen unless you have the divine grace. That way, what they have achieved is phenomenal in terms of not only in terms of quantity, but also quality, and the transformation, the infrastructure has gone through is unbelievable. That way, I think I'm very sure that it's a facility which is very much needed in the rural part of Madhya Pradesh and UP, and they are doing phenomenal work. And coming to the mobile model, I feel that it's very appropriate at this point of time. I don't think we'll be able to start the camps for the same reason Dr. Girish Rao alluded to. Now, if you are going to have a camp and the number of patients who are going to come are large, and physical distancing, social distancing, and following all the aseptic protocols, all that will be a challenge. So, and we also don't intend to start in the near future, even though the government has allowed that we can do the camp. Looking at the same challenges what Dr. Girish Rao mentioned, we don't intend to do it at this point of time. And again, you know, bringing them in large numbers to the hospital, we always run a risk of kind of a cluster of infections because of the COVID. So I mean, unless we have the vaccine being available, everybody getting immunized, the camp is going to be, we are not going to do the camps in the same way we have done it earlier. So here I think that the model you have spoken about, the mobile model is definitely, I think we have to put it into use as much as possible. This is a time it is really needed. Yeah.
Sir, I have one question for you and Ashish and maybe others also. See, even though we started practicing after the COVID, we do that few months of non-availability of the services. We do see a lot of people coming with the dense cataracts and a lot of issues. And if that is the scenario in a metro or maybe a city like Madurai, what will happen to people who are in the rural areas, and who is going to take care of them, and are we going to cause problems to them by not taking care of them when?
So, it's definitely it's a moral dilemma. So what we have done in Aravind is we had spoken to all these camp sponsors. We have close to about 700 organizations which work with us, do eye camps. So we have almost with all the hospitals pitching in, we have conducted separate Zoom meetings with these people. And what we have told them is that they can send any number of patients as direct walk-in patients. We are willing to admit them and do the surgery free of cost. So already it has started happening. Maybe in the last month, Madurai alone has done about close to 200 patients, such patients who are referred by these people. And the second step, what we have taken is we have also started training the local volunteers of the NGOs who are doing healthcare activities for them to diagnose these patients in the community. If they're able to diagnose these patients, we try to help the local group to organize their transport, come here, and we also see that we can operate them. Maybe the day they come, we do all the investigations, do the surgery, and get them back the next day or even on the same day. So we are trying out different models at this point of time to reach the community. So I mean, that's all our moral responsibility. So.
Yeah, one point to add on from looking at the backlog, I think there will be a huge backlog of patients with cataract and other complicated eye diseases will increase, and they will, I think the problem of accessibility, which is going to be a major challenge until all the transport facilities is available and the lockdowns are completely lifted. So
sure. Yeah,
nobody has a idea how much it is going to be. So I think even the cataract surgical rate would probably go to the least in the past few decades, I think. Yeah, I think
100%. Like yeah. we have done only 30% of what we have done last year until this point of time, 30 or 35%. So I don't think we'll be, so that much people are going to remain.
Yeah, I think that's going to be a big challenge, I think.
Big challenge. What you have gained in the last 10 years may go away if it continues for another year.
Correct.
Yeah. What we have done at Chitrakoot is actually what was our outreach teams. They have been now recruited to the vision centers. So since our outreach camps are not occurring, so a few of them also do, with all the precautions, they do a door-to-door survey and sensitize people to come to the vision center. And then the patient is given an incentive, that is a travel allowance to coming from to and fro from the vision center. So we are actually at present managing around 200 surgeries per day, but that's well below what we were doing last year at the same time. But still, it's when the lockdown, first unlockdown happened, it's an improvement since that time.
Yeah. Shripriya, you want to add up any points?
Okay. Unmute, Shripriya, unmute.
Sorry, I think they have covered it all. We have to really change the way we have been working, but the patients will, walk-in patients are going to be our main contribution, I think.
Yeah.
And Mizu, probably instead of coming back in 10 days, we'll have to change our model of going from that to the next place and doing it, probably change the team rather than the shuttling the vehicle back and forth.
If I just may add to what Dr. Ashish and Dr. Anterior said, I think India, with all these NGOs and so many organizations, has shown that it is able to manage its cataract backlog. So I think even if we defer or delay this for a year, I'm sure we'll be able to catch up to those numbers because we have the manpower, the capability. It's just a question of catching up, because I think with such a robust cataract model that we had, the cataract surgery, we actually now moved away and was operating even patients who are 680 and 612 kind of. So I think a few months delay might push this group towards the 660, but I think we should be able to catch up. I think the key is to get the vaccine in soon.
Yeah. We do some triaging and choose only the more mature ones and operate.
Yeah, I think one of the other major problems which the COVID has also started is hitting off on our training programs. That is a major challenge. Like most of the PG fellows, they feel they're not getting the chance to learn and do operate cataract surgeries. Yeah, because everybody wants to send the patient fast, so their chances are getting. So that the training programs is a big. I think they are the most affected. I think getting a good trained surgeon at the end of the program. I think all the training programs need to be extended post-COVID for many of these, so that their skill levels are completed.
And we'll have to change the way we do the training also, I guess, by increasing the wet lab and the virtual reality if they have it.
Correct.
And have much more. We should have all those scores for. There are so many scoring systems for wet lab training, because wet lab training is not evaluated unless it's a virtual reality machine, which it automatically generates the scoring. And the theoretical background behind the surgical component is not stressed adequately because of our workload. So now that the workload is lesser, I think we have to really stress upon the theoretical backing that they need to start operating. And without that, if they operate, we should send them back to the wet lab. A lot does help, because all these Western people do a lot of theoretical reading and analyzing before they actually touch the eye, and they really learn fast. Whoever we have come across, they really learn very fast, and the respect for the tissues is much, much more than the Indian counterparts.
Can I make a small statement, Sripriya, in relation
Yes,
to
ma'am.
that? I think a couple of years I worked in Singapore, and I have seen how their trainees start this surgery at the end of 2 years, and they're all excellent cataract surgeons. The cataract goes like a clockwork, and nothing happens, and they are so perfect. I think one of the reasons is, as you correctly said, they're so thorough with their theory part of it. They're thorough with the instrument. So third thing, what I feel why they are so good is that every case they do is recorded, every case. And there is a complication, and they will have a session with one surgeon, maybe once in a month or so. Every complication that happens is documented, because nurse take the responsibility to document as a untoward incident. And they go through that, and they will really ripped apart in that sense that this would have been done this way, this way, this way. So there is a little pressure on them not to end up with a complication. So because of that, they try to do every step so well. And it's so amazing to see even a second year doing a phacoemulsification beautifully without any problems. I think that, as you correctly said, they were well prepared with the knowledge. Then they move on to it, and there is a responsibility. They cannot make any compromises. Because of that pressure, they try to perform well. At the end of it, they are all excellent cataract surgeons.
Just to add on at this level on the training, I think training and the service models, I think a lot of tele services like tele ophthalmology at vision centers to take care of the post-op patients, and even for the glass appointments is very important, so that the number of visits to the hospital can be reduced. And one more is tele-mentoring, which is other option which we need to look at, where, as madam has suggested, like recording of surgeries, we can also do a tele-mentoring where the surgeries can be live webcasted onto the surgeon, who can monitor 2 or 3 surgeons and give. I think there was one model which Arvind also tried with the special camera, where they can do a tele-mentoring. Sir, can you add on that?
Yeah, I mean what you mentioned, they've tried it in Arvind Pondicherry. They've done it very well. Like, even a surgeon from Tirunelveli will mentor a doctor in Pondicherry. So, I mean, they also look at 2 or 3 doctors, and they're able to do it from one single location. Also, you can. I mean, it's like, they have been trained only by people in Pondicherry. Now somebody from Tirunelveli sees and gives little more inputs, and it can happen like.
Yes, I think these are some models which I think some of us like, where we have to go and stand next to it. Only those, if required, we can do it. Those who are comfortable and handling to a next stage, they can be all on a telementoring, so that can enhance the speed of their training also.
Sure, yeah. I think we are also refocusing on this training part, and we are now give more time now, because as our panelists mentioned, the number of cases are less. So we are putting more focus on one-on-one training. Now we have a consultant sit with these doctors also, which we are not doing it earlier. So which we were doing it only in the initial training period. Now we sit with them, spend more time and learning that one case they may get. Yeah.
One more which we found with our FACO training program when we did a analysis was training of trainers. Because our program was so successful, all those whom we trained, many of them became trainers. And
Yes.
they themselves have trained a huge number, 1:5 or 1:10 when we analyzed. So when we looked, we had trained 400 and overall, they have trained totally 1,000 people. So which is like, when we look at number of ophthalmologists in India, so like even 25,000, so 1,000 people in a short period of time is a very good model. I think need to concentrate on who are very good and motivate them to become a trainers. That is one thing which we need to add on so that can help in better training and better surgical performance.
What you say is true. Yeah.
Yeah, I just opened the panel for others to add on. So we have about 10 more minutes so that we can, if any points to be added from each one of them, you can add.
Audience questions have been addressed, Sudhir.
Yeah, most of them have taken care. Yeah.
If Dr. Foss is there, I have a question for him.
Yeah, Dr. Foss.
Dr. Foss,
you can unmute.
It's fine. Yeah.
He's there actually, but I think not able to hear us.
The only problem with the simulation model is the cost is so high. I think we were lucky enough to get the simulator through one of the training programs. I think we all, even Arvind, us or any of the big centers, I think the cost and the maintenance of that is very, very high. Yeah. Maintenance is low, but the upgrades are too costly. And now the latest upgrade of the simulator is excellent. They have for various grades or complicated cataracts. You can also have different phaco settings, different vacuum settings, and even they have complication management and also have rexes, like running of rexes, how to rescue the rexes. The current ISI surgical modules are excellent, actually. Yeah, Dr. Foss, Dr. Ravindran has a question for you.
Yeah. Yes, Dr. Foss, I mean, one is, just to reflect on what Dr. Sripriya said, the confidence level of male residents are more than the female residents. Okay, but if you look at the complication rates of male, it is much more than the females.
Correct.
Okay, and what the confidence does is also they are more efficient. They do more volume than the female residents. That's what we saw in our setup. But the complication rates, if you see the women, it's much lower than men. I mean, do you see that kind of a difference in England as well?
Oh, yes. Also, yes, there's a very poor correlation between confidence and competence. It's same as the Kruger-Dunning effect. The most classic example, in the President of the United States of America has got lots of confidence, but his competence can be questioned. It's a well-recognized phenomenon that people have very poor insight to their own level of competence.
Okay. That's true.
So, but that's where supervision and feedback can be helpful.
Yeah.
It's surprising that the simulator is not being used in the United Kingdom and in many of the NHS hospitals. It's not. It was just considered as a pilot study, and he showed a beautiful graph that there's absolutely no complication, no learning curve with the simulator, despite that it's not a part of their training program.
Well, Shika, I think the simulator is really important, but I don't think that was the only feature that was really important. Hearing the discussion, I'm all on the same page here, but intensive training I think is really helpful when you're starting cataract surgery, but when you do it, you learn cataract surgery without distraction, and you're doing lots of cataract surgery every day. That also I think is really important, along with all the other things you mentioned about recording, error analysis, have a mistake, knowledge of outcomes, knowing what goes well, what goes badly. But yeah, but yes, I do like simulators.
I can request a closing remarks from all the panelists if they have any. So then we, Dr. Girish and
closing remark is thank you very much for putting up this program. Thank you.
Thank you, ma'am. Yes.
I think we should thank Dr. Ardiyar and Dr. Ashish, Dr. Foss for sharing their excellent views here. And
In my pleasure.
be safe, be strong, and let's
Thank you.
hope for the best.
Indeed.
I think
Thank you.
thank you all for, I think we had a wonderful sessions, and cataract updates is a regular part of our cataract updates, which happen once in 3 months. So we choose a topic for every cataract update. Shika, I should thank Shika for choosing the topic and putting all this together. And we look forward for the next cataract update and participation from all. Yeah. Sir,
For the audience, do check out our www.cataractcatalyst.in website for the details of regarding the next update. Probably in the month of December, January, we shall have the next update. I thank all the panelists, all the speakers once again for taking their time out.
Thank you. Thank you, Shika. Thank you, Sudhir, and everybody. I mean, it's nice to see the cataract surgical training being discussed in this webinar. It's very important. As a country, I think we really have to do a lot to improve the training of our young upcoming surgeons. I think this is the time now to pause and think about and how do we redesign our training also becomes very important. And we all brought out the lack of cases for training. I think this is the time we have to really think about how we can make it more as effective as what they do in Singapore or in NHS.
yes.
The webinars are archiving all the discussions. That's the beautiful part of it.
Yes. Thank you. Thanks a lot.
Thank you all. Thank you all.
Yeah, thank you.
Have a good night.
Thank you. Yeah.
Thank you very much. Good
Thank
night.
you. Thank you, Sudhir,
All the
Shika, Dr.
All
Rao.
these are available in the
Bye, sir.
Yeah. Yeah.
Thank you.